examination of abdomen. And abdominal examination comprises of a few more things to examine. Number one, abdomen. Number two, breasts in female. Number three, supraclavicular fossa. Number four, number five, back. And number six, digital rectal examination. So 6 things we have to examine along with that. These are adjuncts to abdominal examination. And abdominal examination starts with introduction, consent, and exposure. Position of the patient while examining the abdomen. Exposure, the normal ideal exposure is from nipple to mid thigh, but we have a limited exposure which is socially acceptable. Number 2, arms by the side. Number 3, face towards the opposite side. Number 4, legs extended. Then comes inspection, and inspection is of 3 types. 1, keen inspection, inspection as if you want to find something, you want to search something. So that inspection should be like this. So I can see a spot here, a mark here. So this is keen inspection. The second inspection is inspection by the side. अम्मा जी लंबा सांस ले, ठीक है. And the third inspection is the inspection from the foot end. अम्मा जी खांसी करे, बस ठीक है जी. I have seen one hernial orifice by right now, that is umbilical and supraumbilical and epigastric area, but I have not seen inguinal area. Because of female, I won't expose the patient. I will place the hands on inguinal region and ask the patient to cough. Khansi kare and will feel expansile cough impulse in the. Phir khansi kare in the inguinal region. This completes abdominal inspection of palpation. First, ask the patient for any pain in the abdomen. अम्मा जी पेट में किसी जगह दर्द है? अभी नहीं. ठीक है जी. ठीक है. The position for palpation of the abdomen is the flexion of knees. गोडे उते कर लो. दूसरा भी abdominal palpation. Patient supine, arms by the side, face towards the other side, knees are relatively flexed, hand flexion at hip. Now ask for the pain. अम्मा जी पेट में किसी जगह दर्द है? नहीं. ठीक है जी. Then you place, if there is pain, avoid that area. If there is no pain, you can start from left iliac fossa and you will make an S. Right? And the position of hand is important. The wrist and the elbow and the patient's abdomen should be in the same plane, not like this, not like this, but like this. You sit down if it's not possible to make that position. So this is superficial palpation for detecting any guarding or rigidity. Number 2, palpation. Deep palpation is for eliciting tenderness, Rovsing sign, Murphy sign, rebound tenderness. This is for deep palpation. Palpation for viscera. And while palpating, you look at the face of the patient. क्यों अम्मा जी दर्द हो रहा? बस इधर दर्द होता है. अच्छा नहीं पूरा इधर भी तुसी हो रहे हो ना? जब दबाए तो ऐसे नहीं. अच्छा ऐसे बिल्कुल ठीक है. पेट ढीला छोड़े, लंबे सांस लेते रहे. राम राम से. But third palpation is palpation for viscera. Now I will palpate for viscera. जी साह लेंदे रहो अम्मा जी लंबा. Try to understand the mechanism. You place hand, जब abdomen goes down, your hand goes down, but it stays there while inhaling. ठीक है.
दबाएं तो
जी बस सांस. जी ठीक है, सांस लेते रहें. So this is palpating the lower border of liver. Percuss by identifying the manubrium sterni and second intercostal space, and you will percuss it. So 6 intercostal space to costal margin. This is the span of liver. Then we have palpated the for spleen, then you palpate for bladder with your left hand. And then ballotment of kidneys. Place the hand on the back of ballotment. Sign is done. The first palpation of kidney. So you stabilize, you palpate kidney like this. Then ballotment. You stabilize your hand and then push from behind to see any enlarged kidney touching your hand. To feel any kidney touching your hands. So this is palpation. But during this palpation, we have found a lump here. So we will now focus on this lump. First, lump surface. Surface is smooth. Consistent surface is smooth. Consistency is soft. It's not fluctuant. Transillumination is negative. And then going laterally, you define its margins. अम्मा जी ये वापस चला जाता, ये गोला अंदर चला जाता पेट विच. अच्छा जी ठीक है. If it would have been a reducible hernia, we would be able to feel the size of defect by inserting finger in that area. So as it is not reducible, so we can't feel the size of defect. Next we want to know whether this lump is intra-abdominal, within the abdominal wall, or outside the abdominal wall. Within the abdominal wall or outside the abdominal wall lump, it will become more prominent on doing Fothergill sign. अम्मा जी टंगन लंबियां करो, दोनों पैर जोड़ो जी, दोनों पैर उत्ते उठाओ. Look at the cornet sign. So either it is outside the abdominal wall or it is passing through the abdominal wall. By raising intra-abdominal pressure, it becomes more prominent. So this is called Fothergill sign. It can be done in the other way. Amma ji utta utho sar uthayo. So this is the other way of doing Fothergill. Bas theek, Fothergill sign. Then is percussion. So you percuss for viscera. You should have so much practice that there should be clear and loud sound. percussion for जी ठीक है जी bladder. Now percussion for lump. So it is resonant on percussion. Then auscultation. Auscultate, as we know, it has expansile cough impulses positive in this patient. The most likely diagnosis is hernia, and hernial contents can be bowel. So we will hear the bowel sounds. You can hear tinkling sound in this lump, meaning that it contains gut. So this is abdominal examination, and in adjunct to abdominal examination, we will check breasts of the patient, supraclavicular fossa, back, chest, and digital rectal examination.